Good afternoon, and I want to welcome you all to our talk on Mosaic Management of Substance Use Disorders and uh, and heart infections of cardiac patients, a collaborative model and Cleveland Clinic initiative. At the top, we would like to acknowledge that none of us have any disclosures. During this talk, we have three objectives. The first is to identify opiate use disorders and co-occurring psychiatric conditions with infective endocarditis and how to appropriately treat these psychiatric conditions. Two, describe strategies to address patients with infective endocarditis and substance use disorders with or without co-occurring psychiatric conditions. And three, apply strategies for increasing collaboration between psychiatry, infectious disease, cardiothoracic surgery, social work, and post-discharge services. Now, big picture, and to set the stage for this talk, there was a need noted within the Cleveland Clinic system. How do we help guide treatment for patients with infective endocarditis that have substance use challenges and other psychiatric conditions, as these can be some of the most marginalized patients, and subsequently it can be magnified by the treatments for the medical and psychiatric conditions impact the possible care given to the other condition. So a multidisciplinary initiative and approach was implemented with 4 goals. 1, standardized protocols throughout all aspects of care. Early identification of patients, leading to early care coordination. 3, support and resources available throughout the stay and post-discharge. 4, tracking of outcomes and using of data, and using that data to monitor progress, see continued deficiencies, and modify based on that data. Now that the stage is set, let me introduce Dr. Nabin Shrestha, who is an ID physician and part of the cardiovascular infectious group.
I will start with a brief overview of the medical aspects of infective endocarditis. The Cleveland Clinic is a large referral center for infective endocarditis. In the last few years, we are seeing more than 300 cases of infective endocarditis every year. Most of these are treated surgically. Part of that is, of course, the disease itself, but some of that is also because patients are specifically referred here for surgery. Infective endocarditis is not a common disease. It is estimated that in the United States, there are between 10,000 and 30,000 new cases every year. Over 80% of these are caused by staphylococci and streptococci. The disease is changing somewhat. Patients that we're seeing with infective endocarditis are getting older. A higher proportion of patients with infective endocarditis have prosthetic valve endocarditis. And we are seeing an increasing prevalence of staphylococcal and enterococcal infections compared to historically where Wardyn's group streptococci were the most common pathogens. And all of these are because of advances in medical care, advances in cardiovascular care, where there's more complex procedures and more complex surgeries being done. Infective endocarditis among persons who inject drugs has always been a problem. It's an important public health problem, and that mirrors the opioid use disorder problem in the United States. When we think of infective endocarditis, we think of it as either native valve endocarditis or as prosthetic valve endocarditis. Whenever there's any artificial material involved, as when you have a prosthetic valve or even with a prosthetic ring, we would consider that to be prosthetic valve endocarditis. When you have infection of heart valves and there's no prosthetic material involved, we would call that native valve endocarditis. The presentation can be used to classify endocarditis into acute or subacute endocarditis. Endocarditis that presents within 3 weeks of onset of symptoms would be what we'd consider acute endocarditis, and endocarditis that has been going on for at least 3 weeks at the time of presentation would be considered subacute endocarditis. The pathogenesis of infective endocarditis has two components. The first is valvular endothelial damage, and valvular endothelial damage may be related to trauma, turbulence, metabolic changes, or even just degenerative changes on the valves. The second component is the presence of microorganisms in the bloodstream. And microorganisms in the bloodstream generally get there through microorganisms that are normally present as colonizers in mucous membranes, skin, or other parts of the body. When there's trauma to these parts of the body, these bacteria can get into the blood. And a combination of valvular endothelial damage and the presence of bacteria at those sites leads to colonization of microorganisms, leading to an infection. The clinical presentation of endocarditis is essentially that of fatigue or fever in a person who has a predisposing cardiac condition or injection drug use. So when patients have that, when patients come in with that particular presentation, the presence of a new regurgitant murmur increases the likelihood of that person having endocarditis. There are certain clinical scenarios where you should have a high suspicion of endocarditis, such as if you have a young adult presenting with hemiplegia, you should always strongly consider the possibility of endocarditis. Similarly, a presentation of a febrile illness that is followed by a stroke should always prompt suspicion for endocarditis. The diagnosis of infective endocarditis involves having a compatible clinical presentation that is supported by microbiological findings consistent with endocarditis and imaging findings that are consistent with endocarditis. Now, the diagnosis is not always straightforward, especially in people who have really complicated prior cardiac histories. The diagnosis can be very difficult indeed. There are a few components to the treatment of infective endocarditis. The first I've mentioned is surgery, because we have to remember that when these valves develop an infection, they could get destroyed. And because of the damage, you would need surgery to correct the damage that's occurred. Antibiotic therapy, of course, is to treat the infection. And very, very important in persons who inject drugs, treatment of the injection drug use that's associated with the substance use disorder, that is extremely important. So the antibiotic therapy is meant to target the causative pathogen. In our institution, we generally do IV antibiotic treatment for 4 to 6 weeks. And in people who undergo surgery, that would be 4 to 6 weeks following surgery. Now, there's been a lot of interest with oral antibiotics for the treatment of infective endocarditis in the last few years. And yes, selected patients can be treated with oral antibiotics if they improve rapidly with IV antibiotics over a few days. But the reality is that the types of patients that we see in our hospital, most of them would most appropriately be treated with intravenous antibiotics. We always had a concern that people with injection drug use did not really do too well in the long term. And so a number of years ago, we looked at this in one of the studies that we did over here. We wanted to look at the outcomes among patients with infective endocarditis, among patients who injected drugs. What were the outcomes after surgery in these patients? And so the figure here, the curves that you see represent survival free of reoperation for endocarditis. And we're comparing patients who inject drugs with persons who do not inject drugs. And what you can see is that in the first 3 months, even people who inject drugs do really well. And keep in mind that that's a time when they are in very supervised settings, when they're receiving IV antibiotics, at least in the first part of that. But after 3 months, the persons who inject drugs do very poorly. A large number of them, they require surgery for endocarditis, or they have a relapse of endocarditis. On multivariable regression analysis, what we found is that between 3 and 6 months following surgery, persons who inject drugs had a 10 times higher risk of dying or requiring a reoperation for endocarditis. So that is extremely surprising to us, the extent of this risk. So we always knew that treatment of infective endocarditis in persons who inject drugs was not easy. But this study really highlighted how important treatment of the substance use disorder really was. Now, this study was done at a time before we focused a lot on the substance use disorder. At that time, we used to put a lot of attention into the medical and surgical aspects of endocarditis. But treatment of injection drug use was not that well developed at that time. And so this really requires a concerted multidisciplinary effort from many different teams. The most important in these patients is to address the drug use disorder. And for that, we consult consultation-liaison psychiatry. We manage drug withdrawal when necessary. The patient has to be engaged in substance use treatment. And also, it's important to arrange substance use treatment following surgery and following discharge from hospital. For patients who require surgery, they undergo surgery. And of course, we have to recognize that just because someone needs surgery does not necessarily mean that the surgery has to be done now. Sometimes the operation is necessary, but it may not be all that urgent. And so we plan accordingly. We can get other things in process before the patients are taken for surgery. And then it goes without saying, of course, that we would need an antibiotic treatment. Most of the time, this is going to be intravenous antibiotic treatment, which would mean that patients get a PICC line and they get IV antibiotics, and that would continue for a few weeks even after they leave the hospital.
Thank you, Dr. Shrestha. Now let's transition to Sandra Otto. She's an acute care nurse practitioner with the Department of Cardiac Surgery. She graduated from Case Western University and has been working with the cardiac surgery team for over 20 years.
I would like to speak on the management of substance use disorder and heart infections in cardiovascular patients at the Cleveland Clinic. The surgical evaluation of our cardiovascular patients includes the diagnosis of endocarditis, and that is if it's right-sided versus left-sided. Right-sided is tricuspid or pulmonic valve, left-sided is aortic and mitral valve. The establishment of a multidisciplinary approach is very important for us here at the Cleveland Clinic. Our patients are typically admitted under the cardiology service, and cardiac surgery is consulted, and automatically infectious disease and psychiatry, case management, and social work. If needed, as part of the workup, we also involve our interventional cardiologists, nephrology, neurology, neurosurgery, especially if there's embolic involvement to the brain. Neurology and neurosurgery play a very important role in helping us decide when we could go to surgery and the amount of time that we have to wait to proceed. Hepatology is involved, but if cirrhosis is involved and if the patient has been diagnosed with hepatitis C. General surgery has involvement when there's splenic infarcts that have embolized. Also, ophthalmology. We have had patients that have come in with pregnancy, so therefore our OB department really is very involved also, along with urology if there's a need for urological diagnosis and management. So a part of the surgical evaluation includes lab work, which is blood cultures, basic metabolic panel, CBC, complete metabolic panel, PT-PGT, UA, and nasal swab for Staph aureus amplification. Along with a chest x-ray, EKG, if the patient has a pacemaker, we need a pacemaker check, along with dental consults. A lot of our patients come in with very, very poor dentition, and we need that looked at and examined, and they possibly might even have to have dental extractions before proceeding with surgery. The echocardiogram is the first line of testing to tell us regarding the valves, if there's endocarditis, regurgitation, stenosis of the valves. The transesophageal echo is used for better visualization of the endocarditis for assessment of complications such as with the aortic valve, there's a risk of aortic root abscesses occurring. So the other surgical evaluation testing includes imaging, which is CAT scans, cardiac, abdomen, pelvis, brain imaging for assessment of extracardiac phenomena, along with a full body PET scan may also be needed for confirmation of diagnosis and detection of the original source, and this is highly sensitive study for endocarditis. A cardiac catheterization is decided if that is needed depending on the patient's age and history. With endocarditis, there's always a risk of embolization of the vegetation. So sometimes we have a collaboration with cardiology. If it's too risky to proceed with the cardiac catheterization, we will assess the coronaries via a CTA. And that is always a big decision making for the patients. For angiograms, the patients with mitral valve, aortic valve, endocarditis, there's a chance of embolization to the brain. So we would need a cerebral angiogram if there's evidence of acute infarcts. So that is a timely test that usually done about 24 hours prior to proceeding with surgery. And we have to rule out myocardic aneurysms or cerebral bleed with the acute brain infarcts. If in regards to the tricuspid valve, there's always a risk of embolization to the lungs. So a pulmonary angiogram for evaluation of the septic emboli could also be a test that is needed in the preoperative period. And also there's possibility of line placements that are needed, such as a dialysis catheter for if CVVHD is needed in the setting of acute kidney injury. And we work very closely with our infectious disease team to tell us if the patient could have a mid or PICC line placed. The bacteremia has to be cleared before we put that invasive line in, and our patients have very poor IV access. So that's very important to collaborate on the line placement. So with valvular heart disease and endocarditis, the aortic valve, mitral valve can be involved along with tricuspid valve and pulmonic valve. It's very important to discuss with the patients on the type of valves that could be used. For the mitral valve, tricuspid valve, we would prefer to do repairs, but if there's too much damage to the valves, we have to discuss ahead of time with the patient. Biological valve versus mechanical valve. And we have to make sure that the patient would be compliant to take on the responsibility of Coumadin therapy with the mechanical valve. Here's a slide for an echocardiogram that shows the mitral valve vegetation. And tricuspid valve, you can see the vegetation between the right atrium and right ventricle here. And at the Cleveland Clinic, we have a very multidisciplinary approach for clinical decision making regarding surgical management versus medical management. So we really have to make sure that the patient is going to commit to MAT therapy, be diligent about completing the amount of antibiotic therapy that's needed postoperatively to prevent recurrence of the endocarditis happening. And when that happens, then we're looking at a reoperation for the patient. So surgical management is decided on the severity of regurgitation, persistent symptoms, the size of the vegetation. Usually if the vegetation is greater than 1 centimeter, that's an indication for surgery also. And as spoken earlier, we need to talk about the type of management for the patients, mechanical or tissue valve. When the aortic valve is involved, the patient is always at risk for developing an aortic root abscess. So in that case, there's some indication for a homograft usage. And we cannot stress enough about talking to the patient about if they get a mechanical valve, the importance of the anticoagulation, because it could thrombose the valve, it could be a very big problem, you know, a recurrence of another stroke possibly if they're not taking the appropriate amount of anticoagulation. So there are times where medical management is the way to go versus surgical management. In that, for the medical management, we're collaborating with cardiology, infectious disease. Our infectious disease doctors will, you know, they will give their opinion. Yes, I don't think this bacteremia is going to clear without surgery. So, you know, we rely very heavily on their expertise and evaluation also. But in case the vegetation is not big enough or regurgitation or the patient's in heart failure, we will opt for COPAP therapy per ID. And also we want to make sure that the patient is committed to MAT therapy. So if it's medical management, we offer follow-up appointments with our cardiology department, infectious disease, and cardiac surgery. Sometimes we'll bring the patients back for re-imaging, say in a month, and look at the size of the vegetation. Is it getting bigger? Is it getting smaller? Is there worsening valvular dysfunction? And in that case, if the patient has demonstrated to us that they are committed to rehab and doing well, we will offer surgery. For the tricuspid valve, there's a procedure that could be done to remove the vegetation from the tricuspid valve. It's called tricuspid valve angiovac. And that is something that the patient could be possibly eligible for. And in that case, we would involve interventional cardiology. The challenges with this group of patients is relapse. And also we have to concentrate on the appropriate diagnosis of the comorbidities, the mental health issues. And also hepatitis C, HIV treatment. We definitely don't want the patient to develop cirrhosis of the liver, because when there's cirrhosis of the liver, the patient would need a reoperation at some point. That could possibly make the patient not a candidate for surgery. So we're very involved with commitment to therapy with MAT, rehab, antibiotics, follow-up appointments, and access to medical laboratories. And we have to make sure that we establish a secure social environment for the patients. And that includes adequate housing, transportation to appointments. And it's very important in our preoperative evaluation, we're discussing with the families, what is their support? Do they have family support, peer support? And it's very important when our surgeons go to meet the patients that they see that they know that the patient has a person, family member that's going to help them get through this. And it's very important, proper nutrition, that we have to make sure that the patient's going to heal well after surgery, that we get their nutritional stores up. A lot of them come in very malnourished. So that's something that we're looking at very closely also. Before undertaking surgery, we have to make sure that the patient, you know, is committed to keeping their sternum clean, you know, having good wound management and protection of that sternum is very, very important. And sometimes the patient does come in with legal issues. So, you know, that's very important to know what's going to happen. Like if we operate, where will they be discharged to? Do they have to go to court hearings where they happen to, you know, serve out a sentence? And very worrisome for the patients to have surgery and, you know, have to go and have a commitment to filling whatever their legal obligation is. So we have to make sure that the patient has establishment of a good IV placement and management for the antibiotic therapy, and also committed to the antibiotic therapy for prevention of recurrence of the endocarditis. So the postoperative health programs that we have in place, we have an LTAC that the patient could possibly go to, and we also have a wonderful Signature Health residential program that is very close to the Cleveland Clinic. It's within a 2-mile radius. It's called the Orca House. And at the Orca House, our social workers, our case management, have been involved with this program that is offer development of interactive outpatient program, additional psychotherapy groups weekly, individual counseling. They work with establishing life skills support in connection to the Signature Health medical providers. And what is very nice, as mentioned earlier, is that it's very close to the Cleveland Clinic, to where they can come for their follow-up appointments. And that could be, they might even probably sometimes have to go to the Orca House preoperatively. And that's nice to know that they will have access for that follow-up echo CAT scan, looking for propagation of the endocarditis. So we're so grateful for this opportunity to work with the health professionals at the Orca House. So the Cleveland Clinic experience with endocarditis, the cases have significantly increased since 2020. From 2002 to 2020, there was 447 operations for mitral valve endocarditis alone. In 2024, there were approximately 230 endocarditis surgeries for mitral valve alone. The risk of reoperation is very high when IV drug use is present prior to surgery. It could go up to even 64% chance of needing a reoperation versus reop for valve without IV drug use is at 5%. So here at the Cleveland Clinic, we are so very grateful to work in collaboration with our infectious disease department, our psychiatry team, and all of our teams that are involved with the care of this group of select patients. So we are so grateful for our multidisciplinary approach to getting the best management for these patients. Thank you for the opportunity to speak at your meeting.
Thank you, Sandra. Now let's transition to Matt McWeeny. He is a psychiatric nurse practitioner working on the Cleveland Clinic CO service since 2017, and he's one of the primary initiators from a mental health perspective within the Mosaic program.
In this next section, I'm going to cover the role of the Consultation-Liaison psychiatry and the approach we've taken as a team within the Mosaic program. So to start off, wanted to make sure touch base on the primary objectives of the Mosaic program early on when it was implemented in 2017. With the goals being, number one, take a multidisciplinary approach with standardized protocols for pre-op, peri-op, and post-operative care. 2, early identification of patients and care coordination from admission to discharge. 3, support and resources throughout the hospitalization post-discharge through regular follow-up calls and continuity of care. And 4, to track the outcomes and modify program based on data. Early on implementation, we'll say that it's been paramount to have the support of our colleagues in medicine, infectious disease, cardiology, cardiothoracic surgery, and social work. Without the teamwork and build of the program together, wouldn't allow us to best care for our patients. So specifically, the goals for our CL psychiatry service, and prior to starting the Mosaic program, we had a fairly disjointed approach to patient care. We have a large consultation liaison service and providers that work on it throughout our both main campus and hospital system. The first and foremost was to take a standardized approach to care. And that was one, looking at the current evidence-based guidelines and making any updates as far as treatment of opiate use disorder, substance use disorder, and co-occurring mental illness. We worked closely with our lead addiction psychiatrist, Dr. Dave Stream, to come up with our approach overall as well. as far as initiating medication-assisted treatment. More often than not, a higher percentage of using and starting buprenorphine while in the hospital, but instances of using methadone and other adjuncts as well. And another big piece that I think often gets time left out that I'm going to talk about a little bit later on the slides is how to help manage both patient caregiver expectations, given the nature of the hospitalizations and some of the difficulties that arise, and really speaks to the liaisoning aspect of our role within consultation liaison psychiatry. So our initial psychiatric interventions, obviously patients enter our hospital system in various ways and different modalities, coming through the emergency department, coming in as planned, maybe procedures. And one of the big things in awareness we had to have early on and from our CL psychiatry service was based on the multiple avenues, patients are not always getting admitted to our cardiology service or into one of our cardiac ICUs, maybe admitted to our internal medicine service or other service lines. Important for us to get early intervention, not just for our patients that are entering through one of the cardiology service lines. And that's catching patients, with admissions that are secondary to any intentional, unintentional overdoses, and dealing with some of the other sequelae of IV drug abuse outside of infective endocarditis, our patients that are coming in with more concerns for cellulitis and abscesses that may, that have similar issues and may take a similar care path and treatment approach that we need to take. One of the big things, and obviously from our consult service line, is patients that are being treated for acute opiate withdrawal during their hospital admission. Given the nature of patients coming in into the Mosaic program and how medically ill they are, and what type of psychiatric intervention that we want to have, not only identifying the opiate use disorder, co-occurring substance use disorders, mental health disorders, the ability to even get to the point where we can have candid conversations and talk about treatment plans and realistic options, usually, begins with us building that foundation with the patient and managing that acute period of opiate withdrawal. Also a critical period to make sure that our patients are not hopefully making that effort to leave the hospital before that they can get the care and the workup they need to put a treatment plan in place. Obviously, as well, the opiate use disorder and other mental illness concerns coming up throughout the admission process or even later on in the hospital admission. So we end up seeing the patients at various timelines within their treatment process. Briefly wanted to touch on the stages of change here, obviously from our CL psychiatry service line, using various motivational interviewing techniques and skills in order to see where patients may fall in that stages of change model, how we may help motivate them and bring up the subject as far as treatment goes. And again, falling into one of the following stages of pre-contemplation, contemplation, preparation, action, maintenance, relapse, really too is going to depend on how they're entering our hospital system. Are they, in a period of acute withdrawal, these conversations that are likely going to take hold down the road a little bit, right? Managing the acute withdrawal symptoms first, and then getting a little bit more into where each patient lies and what our opportunity is to help intervene in their care and help with them with immediate and long-term goal setting and planning. And this huge piece of this too, obviously, is with the rest of our team here, that these conversations are always ongoing and evolving throughout the hospitalization. and allows us to best, capture the best plan for each patient. One big piece for us, and I think often is not as considered as much as far as starting medications and identifying co-occurring mental health disorders that may require and improve from medication management, is really helping manage and overall expectations for the patient and our own caregivers. And really speaks to that liaisoning role that is unique to our psychiatry section. And this is a piece that I really enjoy. Can imagine patients coming in the hospital and finding out for the first time of how medically ill and challenging and serious nature that may need a significant cardiac open heart surgery for valve repair. And we're not preparing to hear this news and come into the hospital, and you're going to have a variety of emotions trying to come to some conclusion as far as their treatment goes. And that manifests in multiple ways, and fear and some shame, indecision, and leads, not just for the patient, but for the caregivers to start questioning how to best approach and care for these patients during an incredibly difficult time. And these, one of the ways that we have done that is really through education, both formal and informal, for the nursing staff. And anytime we're talking with teams, we're always trying to provide some tips and provide information, educational topics for our nursing staff as a whole. We created a mini series of video lectures on opiate use disorder and co-occurring mental illness, and just a high level overview, just to put some information out. But again, caregivers struggle oftentimes with this patient population and can consider challenging at times. And it's really helping them best maybe set their expectations as well. And is there an opportunity? Is there some counter transference that's happening that we need to discuss as well? So in order to accomplish this, big things is clear communication, not just from us, but that's across all of our teams. Clear communication to the patient and vice versa, and really setting those goals and boundaries while they're in the hospital. Lastly, just wanted to touch base here on our medication assisted treatment. And so far in the presentations have discussed in the need and the importance of starting medication assisted treatment while patients are in the hospital, right? Working through some of those stages of change, and gives us this opportunity to present various options, to start something in the acute period and discuss long-term strategies and options. Overall, the largest percentage of our patients we end up starting on some form of Suboxone, occasionally just buprenorphine itself, Subutex formulation. We do get patients that come in on methadone, and in those instances, something that will continue on if that's what they want to be on long-term and what they think is going to be more successful. And again, Vivitrol, obviously, something that's going to be more of a long-term option. Other medications that are out there, Sublocade, the subcutaneous buprenorphine option, used less often in the medical setting here historically. So some of the things too that we educate once we're starting Suboxone and with the patient, with the nursing staff, is to using the clinical opiate withdrawal scale in order to induce a patient on Suboxone, and that close monitoring during the hospitalization. Never-ending cycle of education for patients, for caregivers, and that communication that really is paramount to be successful. Really coming up with that discharge planning, being that we get patients from across the state lines and needing to find appropriate follow-up care so that at discharge, and whether that's staying local for IV antibiotics and immediate psychiatric care, or this is long-term follow-up once they kind of return home. And if it's away from the Cleveland Clinic, having a solid foundation plan in place to allow patients to be successful and hopefully avoid those instances of relapse in the future. Thank you.
Thank you, Matt. Now we'll move on to my portion, and I just want to introduce myself. I am Jacob Wardyn. I am a CL Fellowship trained psychiatrist and a recent graduate of the Cleveland Clinic CL Fellowship program. Currently, I'm the director of the CL Psychiatry Service at Cleveland Clinic Akron General and an associate program director for the Cleveland Clinic Akron General Psychiatry Residency Program. So let's talk through the social work and care management aspects of the care. The social work and care management team have 4 major responsibilities. First is with resource assistance. So they are going to work closely with the patient and the medical teams to determine the most appropriate resources for the patient upon discharge. Second is discharge coordination. They're going to collaborate with all the parties to assist in discharging to the most appropriate facility. This is typically going to be based on the care that is medically required and the resources that are needed by the patient. 3, they are going to discuss the Mosaic program with the patient. They will discuss it in detail and also give information to the patient. 4, they will start with peer support coordination, which I will discuss the peer support in more detail in subsequent slides. There are multiple factors to be considered and barriers to be aware of with this population of patients. So when there's a discussion on discharge, questions to think about. What are the substance use disorders and the psychiatric illnesses present? What do the social determinants of the actual health look like for the patient? So where do they live? Who do they live with? Do they have financial challenges? Do they have any challenges with getting access to care? What does their support system look like? From a medical side, what has been or what will be the endocarditis treatment needed? Are there going to be expectations for physical limitations, pre-op, post-op, or just when they're doing medical management? Further, will they require central line access for the IV antibiotics? As was noted by our ID colleague, typically there's going to be IV antibiotics for up to 6 weeks. And further, going into very specific barriers, the first barrier that can be thought about or can be seen is, what is their insurance? The vast majority of patients that come through are going to be on Medicaid. That then gets to another typical barrier seen. Where are they from? Because if they have out-of-state Medicaid, there's going to be no coverage for post-acute care for patients who have out-of-state Medicaid. Third is, what does the discharge options realistically look like for that patient? Say they go to a skilled nursing facility. Most skilled nursing facilities are going to have limited options when we're talking about medication-assisted therapy. Or if we're talking about need for more psychiatric support, they might not have access to an IOP. If we're talking about a long-term care facility, there's usually pretty restrictive or strict admission criteria. Can they go back home? Well, sometimes that is an unsafe option or an unrealistic option for the patients. For peer support, we have a local support group or a local group called Project SOAR. SOAR stands for Supporting Opioid Addiction Recovery. It is a collaborative community response to the opioid crisis with 3 primary goals. Reduce the opioid misuse and fatal overdoses. Provide rapid access to treatment and recovery support. And evaluate the impact of the program to see if it could be replicated. SOAR falls under the umbrella of another local project called the Woodrow Project, which actually receives funding from the Ohio's State Opioid Response Fund, which is managed by the Ohio Mental Health and Addiction Services, which is a part of the Substance Abuse and Mental Health Services Administration. SOAR is a peer support model with a team of certified peer support specialists. These specialists have on average 4 years of recovery experience, and with being certified, their certification requires training, background checks, and 30 hours of continuing education each year. The data from this peer support is positive. There's been an increase in employment, social connectedness, and satisfaction with self and their actual health, and decrease in substance use and stress levels. So I brought up that the social work team typically goes in to discuss Mosaic. So this is the first page, or the standard top page for the dedicated binder that they give to the patients who are going to be involved with the Mosaic program. So when they go in, they discuss the program in detail, but they make sure to leave behind a binder that has all of the aspects of the Mosaic program. So they can go through and the patients can read it at their leisure. And it really allows for the patients to go through at their own pace. Because as it's been brought up, this can evolve over time, and depending on how medically unwell they are or what's going on, this really does allow for us to meet them and to meet the patients where they are. So we've gone through multiple different aspects. We've gone through the infectious piece, we've gone through the cardiac piece, gone through the psychiatric piece, and the case management piece. Well, now I think let's go through the specific aspects of the Mosaic program, but let's use these standard algorithms that were brought up initially to walk through how we engage a patient that is involved in the Mosaic program. Do want to give a caveat. There are multiple of these algorithms depending on where they are in the care. I only am going to bring up 3 just to highlight in general how this goes. So first, let's start at the top. There is somebody who has the diagnosis of infective endocarditis. They are going to be evaluated for a substance use condition, especially when there's concern for it being related to an injection. As it's brought up, this is when we start to get collaborative and start to bring in all the different specialties: cardiology, cardiac, cardiothoracic surgery, infectious disease, psychiatry, care management. The other thing is we also have other support systems throughout our system. There's art, music therapy, so we get that involved. And then there are several things that start to happen simultaneously. So as we've talked about, our our infectious disease colleagues will start to discuss about the required antibiotics and what's going to be happening there. From a psychiatric standpoint, the first thing that we're going to assess for is there a substance use disorder? Specifically, is there an opioid use disorder? And then from there does this person require or have they already been on some type of medicated or medication assisted therapy? And so then we're trying to navigate that to see what the best next best options are going to be. On top of that, we are then, as was communicated, we are collaborating to figure out the most appropriate plan of action from a psychiatric perspective, not only for the substance use, but for the expectations and for the other psychiatric conditions present. Now let's go down to care management. What I think is really amazing and gets to one of the 4 goals is this early identification piece, which allows for early coordination of care. So within 24 to 48 hours of this first part happening, we now have care management involved to assess what's going on from a resource side, to talk with the patients about the Mosaic program, and to start having a discussion about peer support. This is also when, so we brought up, it was brought up about the Orca house. So then that can start to be, so then that conversation can start to happen. This is all happening very quickly early on in the care to at least start to have some of these things set up and facilitated as quickly as possible. And then as we're going through, the patients, because we must meet them where they are, will be able to say whether or not that they are at a place to want or they feel like they need peer support. And so then we can actually get them involved depending on where that is. Further, as was talked about, is so we've done the evaluation. We've started simultaneously with the antibiotics, with care management. Then it comes down to, does this person need surgery or not? And sometimes the answer is no, or it's not yet. And so what is going to be done to determine or to help facilitate that? So if it isn't where they are going to need surgery right now, well, what needs to be done to make sure that they get the antibiotics and they get the support long term with that? Also, if we're say it is yes to surgery, well, is this something that needs to happen right now or needs to happen weeks, months down the road? And one of the things that can be really helpful is this is where the engagement of the from a psychiatric perspective, because try to figure out or try to help assist of how increased risk are they for relapse or to re-engage with substance use. What do we need to do with that to make sure, as was brought up, that if they are more likely to relapse, they're more likely to have morbidity and mortality from the infective endocarditis. So how are we going to navigate this? So again, it's just showing how much this can really depend, or there is a lot of flexibility, and it really does require a lot of clear communication and just transparent conversation about what could or what is going to happen or what could possibly happen. So as we were saying, so now we're getting into patient care or the discharge planning piece. So we talked about the surgery piece, but now it's what are the next steps going to look like? So great, we've got them on IV antibiotics. Maybe it's not ready for surgery, but what are we going to do to set them up for success? So have we gone to the Orca house? Are they able to accept them, or what is the next steps going to look like? Because one of the things that is amazing about some of these places that do simultaneous that do simultaneous mental health care and some rehab, is that they can actually take our patients with an IV access or with that port, which is an amazing thing. So we've had to build these relationships to facilitate that, because that's been a big barrier. And so having that, trying to then navigate that has been a barrier, but now as we have the Orca House, it's been really great. As I've said though, and is one of the things that we must always do, is meet the patient where they are. So say they say no, what are we going to do for an alternative? How are we going to navigate that? What are we going to do? Because maybe they don't need surgery now, but they're going to need it at some point. So how do we set them up so that they will be back and that we set them up for success? So as you can see, this really has over the last 8 years really been to navigate and to try to help what is a cumbersome, sometimes opaque process, and get it so that we can really take care of these patients. As you see, Mosaic is an initiative that we are proud of and grateful to assist and treat a very vulnerable patient population, and that there's been a lot of collaboration and a lot of work between a lot of invested people to really try to take care of these patients. And with that, we all want to say thank you for listening to our discussion on the Mosaic program. We hope you have a wonderful time at ACLP and in San Antonio. Thank you.